Our next speaker is Dr. Ravi Mandapati. Dr. Mandapati is the director of the Congenital and Pediatric Arrhythmia Service at Loma Linda Medical Center and faculty at the UCLA Arrhythmia Service. And he's going to be speaking to us on supraventricular tachycardias.
Thank you, Jamil, for inviting me to speak at this meeting. And you know, I've been at UCLA now for 2 years, and we've been working closely with Kevin and Jeremy, and I think we're doing a decent amount of good work, and I think there's more to come. I'm going to talk in 15 minutes about supraventricular arrhythmias in adult congenital heart disease. Because of time, I'm just going to go over a few cases and few examples. There are a couple of cases we'll also discuss later on when Jeremy presents some cases. So adult congenital heart disease, the incidence of adult congenital heart disease is there's 1 million adults, 90% of newborns survive, and there are more adults living with CHD than children with CHD. And the other important thing is 50% of adult congenital heart disease admissions are related to arrhythmia. This is a paper published in 2009. Here are the admissions in 1998, and this is in 2005, almost double the number of admissions. So I think EPs doing adult congenital work will be in business. Moreover, now with the recent healthcare changes where children till the age of 25, 26 may retain parents' insurance, again, we probably will be seeing more patients. Again, now atrial arrhythmias, 15% of adults with congenital heart disease have atrial arrhythmias. The 20-year risk is 38% in a 50-year-old, and more than 50% of patients with severe congenital heart disease develop atrial arrhythmias by the age of 65 years. So what are the risk factors? Atriotomy, surgical manipulation of tissue, extensive suture lines, multiple surgical interventions, atrial dilatation and scarring, sinus node dysfunction, and the older age of surgery. Jeremy's gone over a lot of these factors. When we look at specific defects and specific arrhythmias, accessory pathways are most commonly seen in Epstein's anomaly and L transposition or corrected transposition, twin AV nodes in heterotaxy, intraatrial reentrant tachycardia, which is a fancy name for atypical flutter, is seen in Mustard, Senning, Fontan, and any patient with an atriotomy. It can be as simple as an ASD or a tetralogy of Fallot or VSD. Atrial fibrillation, again, is seen in patients with mitral stenosis, aortic valve disease, unrepaired single ventricles, and possibly a lot of these patients who've had atriotomies, as they grow older, will have atrial fibrillation. Now, this is the most common kind of SVT we see even in patients who do not have congenital heart disease. This is a narrow complex regular tachycardia. We get all excited when we see these retrograde P waves. This is SVT involving an accessory pathway down the AV node and up the pathway. And this is actually in a patient with Epstein's anomaly. Here's the cartoon of Epstein's. You see this epsteinoid valve. The effective valve orifice is here. And the true AV groove, where the atrial and ventricular tissue are divided, is much higher. Oops, sorry. Now, if you look at this angiogram, this is where the effective valve orifice is, and here is a right coronary angiogram. So this right coronary angiogram truly defines the AV groove. Now, the reason why I show this particular angiogram is when we do procedures on congenital heart defect patients, it's good to know the anatomy and plan the procedure as well as possible, because many times in these patients with Epstein's, you have this area out here where the signal quality is very poor, and sometimes it may be difficult to differentiate which is atrium and which is ventricle. Nowadays, with much more advanced techniques, with some of the 3D mapping systems, Jeremy loves to do advanced mapping, we probably can get by without doing an angiogram. But again, this kind of information is important to plan a procedure. So the patient with SVT, this is, if you see the left side, here's WPW, and this is a narrow complex. This was a posterior accessory pathway. You come on ablation with one beat, it goes. I like to show this slide because it makes me look good. But and this is a right posterior pathway. We tested. This is when I was barely started out, so tested for an accessory pathway, gave adenosine, did the necessary things. There was no pathway. Goes home, and then I see the patient for a follow-up visit. I walk into the room, hoping to say, yes, everything is good. Mom is in Mexico. She brings this EKG, and this is what the patient had. So this is now a wide complex tachycardia, which was actually going down the accessory pathway and up the AV node. And I was stupid that I missed this accessory pathway when I did the first ablation. So this was a slightly unusual accessory pathway. Antidromic tachycardia is when it goes down the pathway up the AV node. So here, this is a pathway where you have it's called a Mahain pathway. This behaves like the AV node, and it's a decremental conducting pathway. And here's the tachycardia. You have the atrial electrogram followed by a pathway spike ventricle. So this is the pathway spike that was to be targeted. And so I found the spot with the pathway spike, come on ablation, and it's an automatic focus. So you heat up the tissue, and you see the rhythm very similar to the tachycardia, and this was ablated. So again, the learning here was, for me, at least that was early on, was need to plan the procedure, need to think of everything, and do all the maneuvers to rule out things. Ebstein's anomaly, again, you can have multiple pathways. Now, when we talk in terms of complex congenital heart disease, isthmus-dependent flutter is seen in about 10%, while intra-atrial reentrant tachycardia, which can be called atypical flutter, scar-related tachycardia, incisional tachycardia, is the largest percentage of these atrial arrhythmias. Focal tachycardia is about 15%, atrial fibrillation is about 2%. Now, what is so difficult, or what are the challenges of ablating these arrhythmias? Number one is access, anatomy. There's large areas of scar. Sometimes it's very difficult to identify areas of scar. You may think that there is scar, but there may be channels of tissue where you can have slow conduction, which may be the basis of arrhythmias. Dilated atria, multiple circuits, unapproachable sites. And the gold standard whenever we do an ablation and we make a line connecting one boundary to the other is to show that we have a line of block. And that is sometimes the most difficult thing when we do an ablation for these patients. Now, this is the 19-year-old post-repair of Ebstein's, came in with this tachycardia. Now, if you look at this, it's about 105, 110 beats a minute. And imagine if someone brought you a rhythm strip of one of these things, you may think it's just normal. But if you look at his EKG during sinus rhythm, you see a P wave with a long PR interval. Now, if you go back and look more carefully, you see that this is a 2-to-1 flutter. You see a spike here, spike here, spike here, while in sinus rhythm, there's only one spike. So again, the important thing here is, whenever you see a rhythm which is slightly faster than normal, you have to rule out 2-to-1 or 3-to-1 flutter. It is always a good thing to try and see if there's an old EKG in sinus to compare with. So typically these tachycardias are usually slower than typical flutter. Often they have 1-to-1 conduction, therefore the patient is more symptomatic and more difficult to detect on a routine EKG, and also there's more than one circuit. So let's show some selected cases. This is the most common kind of flutter that we see. This is the tricuspid annulus. This is red is the earliest activation, purple is the last activation. You're going counterclockwise around the tricuspid valve, and this is the same patient with this flutter, easy to ablate. Now, when we look at these patients, if you see any patients who have a congenital heart defect and a 4-chambered heart, ASD, VSD, double outed right ventricle tetralogy fellow, this is probably the commonest, the channel or the isthmus between the IVC and the tricuspid annulus is the most common culprit. So if you make a line connecting these two boundaries, tachycardia should terminate. Now, this is another tachycardia circuit where actually it is going around a scar, and Jeremy is actually going to discuss this particular patient and the importance of how to detect these arrhythmias and what the approach should be when he presents cases. So this is called dual loop reentry. Now, let's talk about transposition patients. This is a patient with a transposition status post a mustard procedure. The ICD and the pacemaker and ICD leads actually illustrate this is the venous baffle, and here's the lead going into the atrial appendage. And these patients can have arrhythmias. Let me just go. So most of these circuits. So this is the mustard cartoon of the mustard. So you can see this atrial baffle. So there's a lot of scar suture lines here and here. So those could be a substrate. And again, our old friend, the IVC to tricuspid valve annulus, is actually a very common isthmus for ablation. So how do we approach these? Now, this is a CT angiogram of a patient with a mustard reconstruction. So this is the aorta and the systemic right ventricle. So I have the catheter going up the aorta, then across the aortic valve, and then bend it across into the isthmus here. And this was typical flutter. So here's flutter, and flutter was ablated. But is this the best way to do it, and which is the smarter way to do it? Again, this is just in the isthmus you see the ablation lesions. When you look at the isthmus, there is this part of the isthmus which lies in the pulmonary venous atrium, and here is the isthmus which lies in the systemic venous atrium or the baffle. This is closer to the AV node. So there is greater chances of problems of heart block when you ablate in the technique that I showed. Now, here's a map from a procedure which Kevin and Jeremy did together. This is a patient with a Senning procedure, and they've gone across the baffle. Excellent map, and you can see that again, you have red, yellow, green, purple, and the circuit is going counterclockwise. So they went across this baffle into the pulmonary venous atrium and ablated at this side. Sometimes you need to ablate in this region, in this region too, but ablating here is much safer. And that's how typically we do mustard and Senning procedures. Again, there's a much greater experience with Senning for Kevin and now Jeremy, because I think Dr. Lax was doing a lot of Sennings. Very, very important. Whenever you take a congenital patient for a procedure, it's absolutely important to try and get hold of the operative node, because there are a lot of things as to where the scar was, where was the patch, how was the surgery done, which can all be very, very important when we do these ablations. Let's go to Fontans. Now, again, this is the old style. We rarely see these patients nowadays, RA to PA. This is the lateral tunnel, and now here's the extracardiac. This is the patient with a old style RA to PA Fontan, huge dilated right atrium. This is like looking from the base of the heart, from the bottom of the heart. This is the dilated IVC. Here's the SVC, and you have a circuit going around the IVC. This is called pericaval reentry. The problem here is you get rid of one and there's going to be something else, because there's a lot of scar, the atrium is dilated, and during my fellowship training we did a lot of these things, and it helped us to learn, but I think it wasn't a very great procedure. In fact, one of our techs used to joke about what was the suicide rate among pediatric electrophysiologists who ablate Fontans. Typically, our approach nowadays is if the patient could go for surgery, then there's not much point in doing the electrophysiology study, and the Fontan could be modified. This is a lateral tunnel Fontan. And now you can see here's the Fontan baffle. This is this is now the pulmonary venous atrium. So we have one circuit which is a flutter around the AV valve, and there's a second circuit which is a focal atrial tachycardia. So again, multiple circuits. You got to be patient and try and get as much as possible, but unfortunately recurrence rates are high. Now let's talk about this great procedure which the surgeons and everyone else loves, but not so much the electrophysiologist. This is a Gore-Tex baffle, and the theory behind it is that you avoid suture lines, you minimize sinus node dysfunction, and also minimize arrhythmias. But the fact remains that despite the extracardiac Fontan, the substrate for atrial arrhythmia still persists. You still have a dysfunctional ventricle. You are going to have higher atrial pressures. There is going to be AV valve regurg. So just like any patient who's got a structurally normal heart and who's, say, a mitral valve disease or a cardiomyopathy, who can have AFib. So these patients are going to have these arrhythmias. So how do we tackle these? So this is a case report that is published by Dr. Shiv Kumar in 2010. Here's the Fontan baffle. So the action is here. So you need to get across to this side. So how do we do that? So you've got to take the transeptal needle, and it's thick. It's Gore-Tex tissue. You need to go across the Gore-Tex, outside the heart, and then into the heart. And therefore, this is something which is, you better have a very clear plan as to, is there a clear indication to ablate this patient? is there no other option? And if you're going in there, you better spend the time and try and get rid of as much substrate as possible. Couple of other things, when we do these transseptal baffle punctures, it's very, very important to know the anatomy and to get as much help as possible. For example, you see that there is a TE probe here. I remember doing a case with Jeremy and I think, and Jamil was there too. We were doing a transbaffle procedure, and Shiv sitting at the back and yelling, look at the wire, look at the wire. I'm like, shut up, I've got an ultrasound, I've got all these fancy things. I don't need the wire. But that point was actually very important, because the wire on both the RAO and the LAO views was very helpful in determining where not to go, at least. So if you're going to do this, then you better be sure that you want to go here, because it is a risky procedure. So again, this is now across, and then you put a wire across. Sometimes you got to dilate the baffle and then go across and take care of business. Again, important thing is you got to take safety precautions. Make sure that there's anticoagulation. Make sure even before you went in that that there is a good plan to try and ablate as much as possible, because this is not a procedure where you can go back and forth again and again. Now, this is a data which Jamil has published, which is it's very, very elegant. In fact, when you have a extracardiac baffle, and there is a guide with a radiopaque suture on either pericardium or pericardial-like tissue, where you can aim your needle, then the procedure becomes much safer to go across. In Loma Linda, there is a large series now of patients where the pericardial, the lateral tunnel is actually made of in situ pericardium. So it's pedicle pericardium. So this is like, here's the IVC cutoff. This is the step 1. And then they roll it around, and then they make a tube out of this pericardial baffle. Let me play this angiogram here. So this is Brent Gordon's here at the back somewhere. This is a case he and I did together. This is not an adult patient. This is a younger patient, but just to show you and this is a patient with dextrocardia who was having arrhythmias. So here's the Fontan baffle. This is where we need to go. So this time actually we used ICE. This is an intracardiac ultrasound catheter. Here's the transseptal sheath with the needle, and you can see it tenting the baffle. And so in fact, we overdid things that day. I think we had a TE too, but I think ICE was very useful. We used fluoroscopy, and then this is going across, and then getting a sheath across into the atrium for the procedure. Now, an important thing, this patient actually needed a stent, so therefore we had a good reason to go and make this go across the baffle, because he needed a stent anyway. But interestingly, this patient had a arrhythmia which was an AV nodal reentrant tachycardia. And again, in a single ventricle with an AV nodal reentrant tachycardia, there is possibly, I'm sure it's possible, but there is certainly a chance of heart block. And my approach is to try and do as much as possible to figure out that this is an arrhythmia which was not going to create a problem like heart block before going in. So once again, if there is ways to make a decision before we go in for a transbaffle puncture, then that's important. So what are the challenges to successful adult congenital heart disease EP studies and ablations? Technique to access the atrium, Fontan procedures. Many times the isthmi or the channel which we need to transect are wide. Lesion creation sometimes in the scarred atrium could be a problem. It's challenging sometimes to establish line of block, and there are also anatomic obstacles like the AV node, the phrenic nerve, especially if you have tachycardia circuits which involve the right atrial wall, the pulmonary veins in the esophagus. And again, and then surgical issues such as thick tissue, patches, folds, ridges. It's very, very important to have a team approach. It's important to have the adult congenital interventional cardiologist involved. It's good to review the MRI, good to review the op notes. Know the usual suspects. we need to sort of rule out certain common things before we go in. Access target tissue, accurate registration of anatomy. Again, Jeremy loves to do detailed maps, and sometimes I make fun of him, but I think it's very, very important to get very accurate, detailed anatomy. Have a clean map. Make sure that the signals that you're annotating are correct. Effective thermodynamics. Make sure that there is good heating of the tissue. This is also important, interpreting feedback. If you assume something and you start ablating and it doesn't happen, then it's a good thing to step back and say, hey, maybe I'm wrong and maybe I need to reassess. So moving forward, I think these are the various things that would need to be sort of worked on. And I think it's a challenging field. The Fontans, which are the extracardiac Fontans, are going to be the problem that we would have to deal with, and hopefully we'll become better. Thank you.